Here at Physio Matters, we think physio matters. Join as a premium member now and access over 500 videos. Get free tickets to shows and upgrades included. Access at home, work, or on a unicycle to take your knowledge to the moon. physio-matters.com. More content than you can fit in a gym.
Hello and welcome to YouMatter. Hi, welcome to this latest episode of YouMatter, which you'll see when the episode actually starts. I had completely no idea what number we were on. I think I ended up guessing that it was session 27, but I was a bit ahead of myself. This is actually session 26. It's a very off-the-cuff, ad hoc, joyous episode with the wonderful Anna Maria Mazzieri, who is a lady that I got to know a little bit during the pandemic. One of those online COVID relationships, those funny ones where you feel like you really, really get to know someone, but you've never met them in person. And today, Anna Maria was kind enough to drive up to Gloucestershire and come and record the episode with me in my office, which was fantastic. Anna Maria is just the biggest bundle of joy, irreverent, enthusiastic, interested in all sorts of things, a wonderful speaker and thinker. It's a really, I knew it would be a really special episode, and it certainly is. I should give you a bit more background about Anna. Anna Maria is a soft tissue therapist and educator. She is the founder of the school, which delivers a diploma in soft tissue therapy at Exeter and also in Bristol and Birmingham. But that description doesn't do Anna Maria justice. She is so interested in the science, particularly pain science, behind all sorts of therapies, but obviously particularly soft tissue therapy. And for me, she's been one of the people able to tread a very tricky line between emerging science and how we put that into practice, how we marry the sometimes difficult relationship between science and actual on-the-ground practice. And that's why I wanted to have this discussion with Anna Maria in particular. So I think there will be something in here for all therapists, whether you class yourself as a hands-on therapist. Actually, no, none of us are really into the hands-on, hands-off description anymore, are we? But whether you consider yourself someone who uses manual therapy and therapeutic touch and hands-on techniques and explains that to yourself in some way and tries to explain it to patients in some way. If you find any difficulty at all with that, if there's any sort of discomfort in areas where you think you'd like to feel a little bit more in your comfort zone around that, or understand that how to break through that difficulty a little bit more, then this episode is absolutely for you. There's lots of other stuff in there as well. Anna was very intrigued about the contents of my office, and you'll hear all sorts of things that she found on my desk that she wasn't expecting to. So a slightly different episode in that it's in person and that in that it's with Anna Maria Mazzieri, but I think you're going to enjoy it. Sit back. I'll be back at the end. As always, let me know what you think, either via email, in person, and if you are watching it on YouTube or anywhere you can leave a review, then please do, because it does help to push the podcast up the ratings. All right, I will stop talking and get the episode started. See you at the end. So welcome to YouMatter, and my guest and I, who I reveal in a moment if you're not actually watching the video, have just agreed that this is going to be the most relaxed, off-the-cuff, unprepared, unashamedly spontaneous episode of YouMatter ever. And just to start in the way we wish to continue, I just said to my guest, I need to look up what episode this is, because I always forget before I start. And then we thought, no, let's not look it up, because it doesn't matter. It's a session of YouMatter. It might be number 27, it might be number 28, not really sure. But hey, let's go with it. So my wonderful guest, who I've been waiting to meet for at least 2-3 years, is drumroll, Anna Mazzieri.
Good afternoon,
Good
I think.
afternoon.
And just picking up a little, thank you, first of all, Joe. I love those off the cuff chats. Random. Let's talk about random a moment. What the hell is doing a white thread on top of your podcast table?
My desk. Well, at the weekend, I was shortening.
Do you sew?
Well, I was shortening a pair of curtains. It wasn't exactly, making a ball dress. But obviously, I won't tidy that up for at least 3 weeks.
That sounds about me.
That's standard, isn't it?
Yeah. Why would you want to tidy it up when probably you need
exactly.
it in 4 or 5 weeks' time?
Yeah. So we'll leave
That's
the cotton
welcome
reel
to
there.
my world. Let's start with random.
Good. So I think we are going to talk about how to manage the slightly difficult scenario that we're in our professions of having shifted away from tissue-based explanations, not tissue-based therapy, but tissue-based explanations of what we do, becoming increasingly comfortable with that notion in some pockets of our professions, less so in others. But then this discomfort that I'm interested in, I want to pick apart with Anna, is have we brought patients with us? How much do we need to bring them with us? It's almost like, how do we manage this difficult transition phase? And is it fair? Have we been fair to patients? I'm rambling now, but it's that notion. How do we...
Yeah, I love what you just said. Oh, sorry, John.
No, go,
on top of you. I tend to talk on top of people. I would bring in patients with us, and this is such a good point, because I always found at the beginning, when I was trying to help clients making sense of the pain, and actually, I went a little bit too much towards the pain education and moving away from, rightly so, from the biomechanical model explanation, actually alienated more than I took on board. Because the people can come to us, and let's say they might have come to us with already strongly held beliefs, which could have been given to them by societal beliefs, by the other therapists. But if the beliefs is what constituted their understanding of the illness, of the injury, of the pain, and all of a sudden you say, well, actually, do you know what? This is all wrong. Why am I to say that? I work next to a chiropractor, and sometimes, I say it's a chiropractor. We're talking now about chiropractic, but it could be any other therapist. But I often hear people say to me about some beliefs that unhelpful beliefs about biomechanical, about, let's say, the joint, and the way they explain the manipulations. And I say to them, was that useful to you? What did you find? Oh yes, I find it really, every time I go. So I know that already. I cannot go there and tell them, destroy or challenge what they think makes them feel better. So I have to first establish a therapeutic alliance with them, get them a little bit to understand a little bit more, thinking outside the box, actually thinking collaterally about the body, about what we know now, and then get them to reach to the same conclusion by themselves. Because otherwise, what will I get is just a backfire effect. And this is where I absolutely, and I know that I go on and on and on about massage. Massage has a very specific, special place in manual therapy to me. Why? Because it can become a fabulous context. Touch and therapeutic massage can become a fabulous context where those conversations can take place at the right time, when the client is ready, when those questions come in, where you can actually challenge those beliefs in a very client person-centered way. So instead of saying, no, but you're wrong, or would you like to know what the research tells us now? And the client will say, no, I don't, actually, because that helps me. So, so slowly we can say, oh, yeah, of course you feel much better after treatment, because there are those type of contextual effects and non-specific effects. The same for my massage. You always feel better after the massage, but you also keep coming back. So if you still keep coming back with the same pain, maybe it's time that we started finding different approaches. So things like I put them always in their they're very led by them, but you are absolutely right. Can we get them on board? This is really important. Can we get them on board? Because it shouldn't be about us. It's like when we teach, it shouldn't be about our knowledge, delivering our knowledge. It should be about how can we get that person, that student, the attendee, or the client to how do they learn better, and how can we match the way they learn what we got to deliver. I am very lucky because I deliver massage therapy. So massage to me is the context where the communication, the encounter, the advice is given. And because the people that come to me, they're already chosen to come to massage because they enjoy it, I have, I'm more, I have a what do you call it, a hands up, or I'm luckier than other practitioners.
Gosh,
sorry, that was quite long.
No, that was great. I was in awe, and I wish I could have put a paper here. I'll get one, because there were so many things you were saying there that I wanted not to forget. But you've just in one answer, Anna, you've kind of flipped my assumption that actually the problem was harder for you working in a profession that is, by its very definition, a hands-on therapy. And you've just flipped that and said it's because I can put my hands on them that I have an opportunity to introduce it in a way that is more gentle and nuanced and drip feed at the right time, because there's something else going on, and the something else going on is the hands-on. And yes, fine, the thing that's going on with the hands is not stretching muscles, moving joints, changing structures. It's forming that therapeutic alliance, forming connection. I work with a colleague who is an unapologetic hands-on physio and will always be so. And he says his subjective is about 10 seconds long because they're on the bed straight away. And he says, I'm talking to them through my hands.
Subjective is a process. It's not just, and I want to move away from the word subjective. I want to call it, the clinical chat, or the history taking instead of subjective, because sometimes that has has quite a hierarchical.
It's getting to know them, isn't it?
Yeah, it's to getting to know them, absolutely. But it's a process. It should not be just at the beginning of the session. It is, and again, I repeat, with massage therapy or manual therapy, it is all the way through the session. There is actually, I'm a big fan of Georges Estevez, Rossettini, Palin, et al. Over it, not because they're from Italy, not because they're from Italy.
Those names roll off your tongue.
Not because they're from Italy, but I'm quite proud of them. They are osteopaths. They're doing quite a lot of work around therapeutic alliance, and they looked at touch as under the active inference. So they looked at under the active inference model, they looked at touch as a potential facilitator of therapeutic alliance. Why? Because what they're proposing is that through sustained touch, where you have C-tactile fibers, which are stimulated, which they give a pleasant sensation, because they go into the insular cortex, I believe. That's where the sensations and the emotions are processed. So it's quite a pleasant touch. Because of the pleasant touch, that provides trust, that creates matching of prior experiences with the client's brain, and therefore the client feels comfortable, and this creates the trust already, feels that I am comfortable with you, and therefore that's why it can be a good basis for those people that like touch, good basis to establish therapeutic alliance already with the touch. And we'll know from clinical practice, for what little our anecdotal experiences might be valid when we talk about research, but you ask many of my colleagues at any level, and they would say, actually, I asked all the right questions, but the client didn't release the very important information until we were on the couch. And sometimes I would argue, you know, the second, the third, and the fourth. And that to me, and this is why I'm so convinced and passionate about the role of touch in modern healthcare, because the people we see in our clinic are not people with acute injuries, are people with their injuries that they're not acute enough or challenging enough for their daily lives, so that they need to go to a physiotherapist or to the NHS. They approach us with those low-level, minor injuries that affects, though enough, the quality of life, but we see them so much more regularly over time. So we build the rapport, but also we start understanding really intrinsically all the factors that influence that pain, that influence the injury, not only the biomechanical factors, but all those psychosocial and systemic factors. And we are so best placed to consolidate a message that the physiotherapist may have given, to consolidate a message that may be, you know, healthy lifestyle or active lifestyle. And because they trust us, they feel supported by us, and they don't feel told by. We are just becoming part of their team. So that's why often we find that the therapeutic alliance is so powerful to actually help them within their behavior change pathway, because that's what it's all about. It's all about behavior change. But a client needs to feel safe and not judged in order to change behavior.
And what an amazing arrangement within a clinic if you've got a system where you've got physiotherapists, chiropractors working with a client, delivering some of this information. Then you've got a soft tissue therapist. And I think what I understood in your explanation then, Anna, was that you have the opportunity to help the knowledge become embedded and accepted.
Beautiful. The knowledge become embedded and accepted. Absolutely love that, actually. Absolutely love that, because probably because of the touch, it allows us to reinforce the message.
Well, it reminds me of I did a podcast with Joanne Elphinston recently, and she said something she wrote it in the article that sort of prompted that podcast. She said, when you're teaching someone and you're delivering information, you're talking to cognition, and you're talking to that part of someone's brain about something they feel. And then you ask them to describe something about their body, whereas you've almost
interoception.
Yes.
This is sorry, I stopped you there again, but you're absolutely right. And this is where I think the people that come to us, they are self-selecting. You come through the massage therapist door, even if you through referral or so on, because you already know that you respond to touch in a certain way. And why sometimes there is understanding of we help them to make sense of pain, or I hope we help them to make sense of pain. I think interoception has got a lot to do, because we allow to kind of stimulate interoception. So the concept of the internal feeling of the part of the body, that can make them feel so safe. And then when they go out, they can explore a movement, or we help them to explore it within the clinic setting, with certain techniques. We can explore a movement that before they didn't even think they could do. And all of a sudden, they're reconnecting to the part of the body. They're connecting and exposing themselves to a different movement. So they might not have the vocabulary to say it, but they might have that movement literacy. We can expose them to a movement literacy they might not have had before. So actually, it's not only through cognitive expression or cognitive understanding, it's through also, understanding of one's own feelings and one's own embodiment of the actual feeling.
Yeah, and it's so much more real, isn't it? Rather than here's a new theory which I'm really excited about and totally sold on, which I'm going to tell you, as opposed to here's a bit you can you can take on if you want, and when you feel the success of it, then you can trust it yourself.
Oh God,
become more curious.
How many people I must have alienated at the beginning? I got really excited. Oh, got really excited because all of a sudden I was really strongly biomechanical. I mean, I ran all the anatomy training courses. I've done all the possible biomechanical courses. I was really sold on the linear understanding of biomechanics. However, something was not making sense. And then when I started researching a little bit about evidence-based practice and pain science and person-centered care, all of a sudden, actually, all of that made way more sense than before. And I was, I was so excited about telling all my clients, look, and I literally just blurb all of that to them, and they could not care less. That literally, they looked at me, interesting. They just could not care less. I alienated so many people, and actually, probably, I did, well, I know that I did a great disservice to them, because then what I realized, and what in fact evidence is also there to tell us, that they don't want to be told, they want to be heard.
Yeah.
They want to be heard.
Yes.
What a client wants and needs, they want to be heard.
And I think there's an elephant in the room. So I, as you know, own...
what is it?
It's a small office, but we've fitted it in.
Jeez.
There is no actual elephant in the room.
Well, you never know. I mean, she's got a thread.
It's a little thread.
Oh my God! I mean, you're kidding me. When do you have time to sew?
An elephant in the room is now.
Well, tell me, do you iron as well?
Do
you iron?
No.
No, but she threads. She does the curtains, but she does. I'm glad that you don't iron. Yeah, I'm glad that actually. Thanks.
Back to the elephant.
Oh, sorry. Yeah, we thought.
Nice little coffee over yourself.
Nice coffee as well. Doesn't matter. Sorry about that. Let's go back into the elephant.
What was the elephant? Oh yes, the elephant. So people learn this stuff, and I'm going to go straight at it, Anna. Some people learn this stuff from you, and they take it on. It's great knowledge. Then they get to that place that you very honestly have admitted you were at, of wanting to share it all, almost doing this massive epiphany shift for themselves, and then getting unhappy patients. And, as a clinic owner, sometimes you're left with this situation going, well, goodness, I've got this really thoughtful clinician who is absolutely on the money in terms of up-to-date knowledge, but they're putting the patients off, and this isn't a great situation. And the temptation sometimes is to almost want to bring the clinician back into line for the benefit of the patient. But there's a middle ground, which I can 100% hear you found your way to, that there's a danger, isn't there, that if there's too long a lag time between that taking on the new information and then learning how to integrate it in a nuanced way, then it's not great.
Yeah, that's a superb question, because I'm a clinic owner as well. So, and I hear a lot of, therapists, but also people that are already trained, that are in clinical practice. And this is some of the feedback that I hear. And what I would say is, again, we cannot tell the therapist has to self-realize, and maybe asking the therapist the question themselves is, what do you think a good clinician is? And everybody should be person-centered clinician. So what do you think the person might need, or indeed might want? Because actually the person might need some pain educations, but would they want them? And if they don't want them there and then, is there any other way you can deliver the same message? And again, I am so lucky with massage therapy, because I can deliver the pain message, the pain literacy through hands-on instead of through words. Because if I say to somebody, let's say I do a little bit of an MET, and I say to them, look, here you feel pain now, and do the MET and they don't feel pain. That for me is a really good way to expose the person to the fact that the pain cannot be caused by any structural damage. So they can, if they are hands-on, they can use their hands-on as their discussion base. What I learned, and this is absolutely very, very specific for massage therapy, people that come through your door, they don't want to be sitting there for 45 minutes to listen to your knowledge on pain, because this is not what is helpful to them. This is not what they're coming to you for. They're coming to you for a whole interaction, which should always be, discussion, hands-on, in our perspective, and rehab. This is what we are not. I'm talking again, massage therapists and people or soft tissue therapists. We are not in pain clinics. We are in private practice. If on top of there is written massage therapy, that person would like to receive their treatment they would like to receive some massage within their treatment. So to me, that is very, very important. That the person is all provided, if clinically reasoned, the hands-on part. And the hands-on part can be the pain science.
Yeah.
If we want to talk about that, because actually you can deliver that very important message through exposing them through manual therapy to symptom modification, or exposing them to better range of motion, or exposing them to the potential, you can do this.
Yeah, by the results.
Yeah, absolutely. A physiotherapist might be different. So there is less expectations. So when one goes and see a physiotherapist, there is less expectation of manual therapy. And I think that is absolutely right, because of way I think physiotherapy is moving as well as specializing. I am absolutely right. But if you are a soft tissue therapist or a massage therapist, this is why the people come to you.
You say that though, Anna, and I think as a physiotherapist, in some cases, I don't know actually. I mean, the expectation of ourselves is that we will deliver less hands-on manual therapy. I'm not so sure that shifted a great deal with clients. Really? Yeah, I mean, my husband and I were having a drink with some friends last year, and I got into explaining this to our friend, and he listened to it all, and he said, "That's great, Joe, but sometimes I just need to feel like a really hard prod, or I want you to move my joints around." Yeah. And he said, "Even now you've just explained it, I still want it and need it." I'm not so sure that. I guess that's the point of what I was saying at the beginning, really, because I can only see it from a physio perspective, that it feels like we are running and sometimes dragging patients with us rather than all the beautiful stuff you've talked about today.
But this is what we hear a lot from clients, and I think we are into the interim time. So the clients, the one we see, obviously we do not see those ones that they're very, very happy with the service, but the one we see that they're not happy with the service, they consistently tells us they did not even touch us, and what they meant is manual therapy. Okay, because for those people that they respond well to hands-on, the manual therapy is about validating their pain, it's about validating their the lack of range, validating them. And they feel that has been missed. And I think it would be very useful to actually ask the question, what would you expect, which should be all of it, all the time. What do you expect from our treatment? What does an ideal treatment to you looks like? My client will always answer that, will look like massage. Great. To which I say, we're gonna do some massage, we're gonna do some other techniques, but also we're gonna spend the last 10-15 minutes doing a little bit of rehab together. So maybe those therapists that maybe some physiotherapists might actually ask the question, what are you expecting from the treatment? Because it might be that the client expects something that the therapist cannot provide. The other thing also, and this is where I absolutely, and hear that well, don't fall off your chair, I agree with Adam Meakins.
Few people do.
Yeah, I totally respect him. In fact, I think I said it on Martin's podcast that I got a crash for other meetings. So yeah, this is out in the air now, out in the air.
On 2 podcasts.
Yeah, on 2 podcasts. Where it says, no, you know, when people talk about manual therapy and physiotherapy, it's not about touch and physiotherapy. It's not touch that is discussed, is debated, is the dependency on manual therapy. If manual therapy takes away some valuable time, you can deliver other things so that clinically reason might achieve a better outcome, then I can understand that. But touch should always be part of it. So you can have the prodding, but just assessing. You know, so maybe just assessing that. If the client actually says, look, I actually wanted a treatment hands-on, well, let's go through the assessment, let's go through the rehab, but I refer you to my colleague down the road or in my clinic where you can have some really good hands-on treatment, and I can collaborate with this client to make sure that we have a more integrated approach. Because this is what we are there for. This is why I do like physiotherapy, moving away from some hands-on, especially the massage part, because that's how my profession is grown. It's grown because those needs of your clients haven't changed. Some clients want to have their injuries treated through also to add the massage therapy through within the treatment plan. That will never change. Just because science has changed, the needs. In fact, I remember lovely the hip physio I met last year, I think on Twitter, he said, oh, I got terrible neck ache. Why do I just want massage?
I've read that
too.
You
read it?
Yeah.
I didn't, as usual, I never have time to respond.
I'm so embarrassed. I want someone to touch me.
Yeah, I said, oh, I am the classic. Yes, because actually, guess what? For some people, what they want to be held, they want to be touched, they want the pain to be validated, they want to feel better. Feeling better, it's good.
But you know what I've also taken from you today is you said patients want to be heard. And what if for many people being touched equates to being heard? And when they say they didn't put their hands on me, what if that means they didn't hear me? They didn't see me, they didn't understand me.
I love for everybody, I'll send you the link. It's an open access paper from George Esteves, because he says, touch is like telling the client, I am like you. So you can trust me. It is just, it's just so wonderful. So you establish a different relationship you establish, but it's not all touch. So there are, you know, more sustained, affective, what we would call affective touch. But I argue there's some discriminatory touch and some other manual therapy can do that. Because he says, again, and I keep saying that, and nobody picks it up on it, but massage and manual therapy are just the context, context where the true interaction and encounter takes place.
It's your way in.
It's my way in. And I know that people will argue that you don't need that, you can spend, but actually, what about if I love doing it? I've done it for 22 years. I absolutely love giving a massage. I got a skill, my client respond well, I'm matching my skill with the need of the client. As long as it's clinical reasons, judicially reasoned, then I fulfill the need of the client, while at the same time, I'm following evidence-based guidelines.
So you have just segued beautifully into where I want to
segue.
It's like on a Segway, but it's a conversation.
That's really nice word.
Yeah,
segue.
Thanks. And again, I've forgotten what I was going to say.
Oh, sorry, I keep interrupting.
Segue into clinician wellbeing, which is obviously the point of YouMatter. So a lot of this is in my head because my focus being so much on clinician wellbeing, and so many clinicians coming to me in a sort of difficult part of their career. People my age will often describe that it feels like I was trained and then my whole career has been a process of deconstructing everything I was taught, and that's really unsettling. But clinician well-being, well, Anna, rather me put words in your mouth, what is there in terms of clinician well-being in all of this?
Actually, maybe let's start it's easy for me to say, okay, so I do appreciate, but let's start reconceptualizing this deconstruct. Is it deconstruct or is it changing? Because actually, you can see it as a deconstructed everything you learned, or it's learning differently, different things. So to me, that I've been in practice for a long time, when I started following evidence-based and pain science 10 years ago, actually things made sense to me and they were easier. And I thought, yeah, that's good. Yeah. That is making so much sense. This is now why I'm getting this response. Because I always used to say to my clients, I remember it, oh, you get better because of my accent. And bloody hell, now I know they get better because of my accent. They all laughed. But now I say, yeah, you get better because of my accent. You get better because of, you know, our relationship, not because of anything I do. So actually, it's reconceptualizing that deconstruct. The problem, I think, and I think of that all the time, because, you know, like everybody, you know, sometimes I feel I never get the burnout, but I get sometimes quite overwhelmed. I always say to my colleagues, you know, I'm drowning because I'm one of those who takes everything on. And I cannot self-manage myself very well. But I think ultimately, why do we do our job? Especially as, you know, if I speak about soft tissue therapists, massage therapists, I don't know, physiotherapists, because ultimately we want to care for people. If we care for people, if we want to care for people, there is an element there that by default, we put other people first. And so by the time we put ourselves first, sometimes lots of things has happened and it's a little bit too late, and that's why we crash. So maybe we need to understand that, well, it's easy for me to say that actually this is by default, we are carers, but also we should be carers of ourselves. So, but it's you know, it's quite, I think it's quite okay to feel overwhelmed, because the other thing is, isn't that great when you start, not when you're there, but when you're out of the space, isn't that great to think, actually, I went through that. I learned through deconstructing, and now what I deconstructed, I'm come out of it with some of the knowledge, again, some new knowledge, and this is who I am, an experienced, well-informed, and diverse practitioner than I was 20 years ago. I think we need to record. It's not always, but I think also social media kept us telling us that all what we learned was bad. Actually, some of the biomechanical things I learned were great, because it makes me understand about those risk factors. But I had to change some of my quite a lot of my things, and that's okay.
Yeah, no,
you know,
I
that's
agree.
okay.
And I mean, I've said on a few podcasts that I've count myself very lucky that I chose to study. I did a master's in pain only a couple of years into my career. And I think I don't remember particularly knowing why I wanted to do it, other than that I found pain physiology intriguing. And I kind of felt that in my degree, it hadn't gone anywhere near as deep as I wanted to go. I was just, from a sort of geeky point of view, quite fascinated by it. And then when I was doing the MSc and learning about how pain actually works and doesn't work, and how tricksy it is, and all the different things that contribute to it, I always think, possibly because I was young enough not to be unnerved by it, I took it on exactly as you've just described, as, oh, thank goodness. So that makes all of this stuff make sense. But it interestingly didn't make me ever think, well, I'll just stop doing things I've been taught. I just thought, well, I can explain it to myself differently in my head, and that makes a lot more sense to me, and actually gave me more enthusiasm for what I did, not less.
I totally agree. This is what I think, and sometimes I collect my thoughts a little bit and I think, oh, am I just shoehorning, you know, kind of, am I justifying myself by saying that so that I don't have cognitive dissonance? I don't know why it worked for me, but for me it worked. And this is what I try to share with some of my colleagues that have been in practice for a long time, and when they enter into evidence-based understanding, and they say, oh my God, so this one, like somebody said, oh, so the massage doesn't break down scar tissue. Yeah. And, you know, yes, I know that you learned it. I learned it, actually, even worse, I taught it. But actually, that is not an important knowledge to me. It's more important is the fact that actually your expectations, their expectation. You're sitting down with them, you're talking to them. So let's focus on what is important. Let's not focus what we've been told and it's not true, or we thought it different. Let's shift our focus not on the busting myths, but on actually increasing our knowledge of what is possible now. So to me, yeah.
And how much more kindness to each other and to ourselves in that, rather than the I'm going to prove I'm right, you're wrong, or even I'm going to tell myself I was wrong and beat myself up for it. That's for me where the clinician well-being part comes, compassion for ourselves and each other as we all navigate this very complex profession.
Absolutely. Compassion, but also sometimes, Jo, I think we need to know that once we go on social media, you have to expect that some things on social media are said in a certain way. So just read them as they are and move on. Or read them as they are. Like, I keep giving this example of other meetings, but it's the perfect example. I mean, all the things he says about manual therapy, hands-on massage, you know what? I don't get offended, because ultimately what I seek out of his posts is what he does so well. He is so kind with his clients and what he teaches. So actually, let's try to get what is good. And some of these posts, some of those comments, which they can be a little bit controversial, sometimes controversy makes us
causes change.
It's only us that put in too much focus. Well, I say that it's easy, but the times I go home and I go to sleep and my blood pressure goes up. So it's easy for me to say I sound like, oh yes, very secure, very absolute no, because actually I'm quite sometimes unnerved by it. But then, I know that, I pull myself back in and I think,
in the right place.
Yes. Yeah.
So Anna, as I have you here in my office, is there anything you wish I would have asked you about this that I haven't yet?
Well, I wish you would have asked me to sew your curtains for you. because I went to the nuns when I was young and learned about sewing.
Look, can we just put this in context? What I did at the weekend was I stitched 2 IKEA curtains together down a straight seam. I ain't making your curtains for you.
So is there anything
else about my office you'd like to comment on before we finish?
The view is fantastic for anybody who's got the opportunity to do it.
I should invite more of my guests.
And the view is fantastic. So what something that you would have asked I wished you'd ask. I'm so sorry. This is sound an excuse, but I'm not really good when somebody asks me those quick questions on the spot. I don't know.
Do you want to ask me? What do you wish you could ask me?
Oh, that's really nice. Jo, how do you reconcile your very busy lifestyle, busy family, busy work, with always being on top and being so on the ball with your membership group, with you always have so much time for everybody, some of your posts. How do you reconcile that? How do you do it? What is the secret?
I'm tempted to come back with a question, which is, what on earth makes you think that I'm on top of it all and feel together, and that it's not some kind of vaguely managed chaos?
Yeah, because the vaguely managed chaos is obviously effective, because actually it makes me feel calm. Because actually that's really good. Probably that's your skill set. It's about, you represent that's your skill set. You're sharing. You're representing that calmness. It actually gives me confidence that I can still have a very busy, hectic, mental life. It doesn't. I can live well with stress. I can live well with a busy mental. Like we can live well with pain. I'm actually okay to live well with my mental life.
Yes,
because actually, we can do that. And that's probably
But if that's a message I can convey, I'm overjoyed, because I it sounds like you're similar, have spent many years thinking it's wrong to be busy and trying to hide the fact that I'm so busy. Yeah. Because yes, I am interested in absolutely everything, and no, I don't really want to just do one thing, because there's all those 99 other things that are interesting. So what I've learned in more recent years is the only thing I need to watch is my own regulation. So as long as I can keep myself in a place where I can be most of the time that calm, safe place for other people, then it's okay to be a little bit scatty and chaotic. I know that I've pushed it too far when I'm no longer that safe place for people, and people give me very clear feedback at work and at home when I've crossed that line, because I can get there. I just get too busy, and then I'm not there for people. I don't have enough attention. But I've learned that it's not a crime to do lots of things, but just keep a mind on what is too much.
What you said there, so many, it's just so lovely. I know that this is completely different. We cannot restart another podcast on it. But when you said
29 or 30
podcasts in one, the fact that actually I'm okay to be who I am. Actually, for some people say, "Oh, you must be really stressed." Oh gosh, I'm not. I'm just interested in a lot of things. And people say, "Oh, you're a workaholic." No, my hobby is my profession. It might sound sad to so many people. My family is always at the forefront of everything. But if somebody says to me, "Anna, what's your hobby?" It's my profession. I love it. I find that interesting. I don't want to feel guilty because other people think, "Oh, you need to have a life," or "You are too stressed." I might be stressed under your perspective. Actually, more things I do. We're driving up today. Wow. Phone calls, podcasts. Great. I was so, engaged with everything because I was doing 2 or 3 things at once.
So but then you're right. Yeah. So now what do you need to just regulate a little afterwards?
Yes. Yeah. I get very, very tired. So there is a point for me. So that after the point, I know it. That's why I don't work certain hours. That's why, because I absolutely switch off. Even socializing, if I go out one evening, the day after, I have to have time by myself. I get very, very cognitively
fill up again.
Yeah, and I'm okay because now I know it. I know that it's not being lazy. I just know that if today is quite busy day for me. Yes, it was when I go home this evening, I just walk in my dogs. I don't talk to anybody, which my husband is quite pleased about it. And I don't do anything apart from what I want to do.
Yeah, lovely. So, well, talking of vaguely managed chaos, I hear while we've been talking, the dog and the kids have just come home. So probably time to wrap this up. But I'm so grateful to you for making the effort to come up to Gloucester and visit me and do this podcast in person.
It's lovely. Best coffee. She made the coffee in a cucuma, in a proper percolator. This is for you, Rob Bevan. She's got proper coffee, illy cafe, and a cucuma, a proper percolator. So other coffees are available on the market, but she had illy cafe, which for those of you that I understand, this is good. Very nice coffee. Superb cups, because we know that context matters. And that's
it. So if anyone else fancies being a YouMatter guest, you get good coffee, you get to sit in my office and look at all the random, I was going to say rude word, stuff on my desk, and look at a lovely view out the window. Right.
Thank you, Jo.
Should we stop now before we make podcast 31?
Thank you.
Thank you so much. Now I need to find the stop button. Can't find that either. That's fitting to the end of this, isn't it? Oh,
it's the double takes.
So there we have it. I hope you enjoyed the episode. Thank you for listening. I hope you found some useful information, and I hope you had some fun listening to the conversation. I should have asked Anna at the end how best to get in touch with her. I know that Anna is on Facebook and also on LinkedIn, but if you would like to get hold of her via email, her email address is info@theschool.co.uk. That's certainly a good place to start. You'll get hold of Anna Maria that way. Let us know what you think. Did you agree with what was said? Did you agree with some of it, disagree with some of it? Have you got any further insights as to how we carry this situation forward in terms of our understanding and how we bring patients with us or not? Let me know. It's a conversation that is in a more comfortable place, I think, than it was perhaps 2 or 3 years ago. I think we're starting to find our way a little bit, but there's further to go. Let me know what you think, and I will be back for Truly session 27 and look forward to seeing you then. If you are a busy clinician looking after yourself and other people in all spheres of life all day, every day, then don't forget to take a breather. Remember what Anna Maria and I were saying at the end about it's okay to be busy, but you need to understand when is the time to pull back and rejuvenate, reset your own nervous system, recalibrate so that you're ready to go again, because you matter.
There are 2 things that all MSK therapists have in common the world over. They love free trials and exercise prescription. So if you're a chiro, physio, osteo, or some sort of os-chiesio hybrid, then head to rehabmypatient.com/physiomatters now and get 3 months on us of the best exercise prescription software available.